really grateful, deeply grateful to these events organizers for giving us the opportunity to share with you the major results of the phase 3 trial, Fil-Rouge, the Fil-Rouge trial, that is an important phase 2 trial conducted by the Italian Lymphoma Foundation, Fondazione Italiana Linfomi. These data were presented in the plenary session by Dr. Pinto, and they describe our efforts to improve a traditional platform and the common platform that is the Abvd by introducing into it the German principle of the first hit, the Kairos effect, that is to say, hit earlier and harder. In this slide, as you can see with the traffic light system color, we see the three strategies that in the last decades were present in the treatment of Hodgkin lymphoma. The early intensification prompted by the German study group, which achieved very high progression-free survival rate at the price of a cumbersome toxicity, almost universal sterility, secondary neoplasms. Then the further intensification exploited by the PET-adapted trial, which had, on the contrary, not so satisfactory progression-free survival rates, however, were confirmed the profile, the safety profile of the treatment. Then the third, with the abandonment of both intensification and both PET adaptation to introduce novel agents such as brentuximab vedotin and nivolumab to the Abvd backbone. We tried to realize a trade-off between the intensification upfront and the safety and the safe profile of the Abvd. And so, to this aim, we compared a traditional PET-adapted Abvd with a regimen, Abvd, dose dense, dose intense, that we first explored in Naples and whose results were published some years before. We had a different Abvd regimen. The differences are mainly two. First, we reduced the intercycle between the treatment courses from 28 to 21 days, and second, so that the drugs are delivered on day 1 and day 11 instead of day 1 and day 14. And second, we enhanced the dose intensity of doxorubicin, that is to say the most critical and active drug of the combination, changing from 50 to 70 milligrams square meter per cycle. And the progression-free survival rates were satisfactory, and especially if you want to consider that we did not adopt radiotherapy. And the regimen was so just as it was in the original phase 2 trial, was compared with a PET-adapted strategy. And the two arms were randomized 1-to-1. Patients were adults up to 60 years old, and the treatment was stratified according such factors, bulky, stage, and also IPS score. Radiotherapy was, it doesn't work, was delivered in such kind fashion. And so we have to treat the PET-positive PET-Abvd rests greater than 2.5 centimeters in the dose-dense, dose-intensified schedule, and the same in the other regimen, but with a treatment of the initial bulky by default per protocol. And this is the key statistical endpoints. The primary endpoint was the progression-free survival at 3 years. The events included in the event-free survival are stringent. We also included discontinuation for any reasons and grade 3 and 4 cardiac and pulmonary toxicity given the enhanced schedule of treatment. And the target was to have an improvement in the progression-free survival rate of 10% over the 75% survival in PFS that was achieved by the PET-adapted program. Demographics is representative of the most trial in Hodgkin lymphoma in advanced stage. We have a high fraction of bulky disease. The randomization up front helped to keep well balanced the two arms. This is a complete and detailed and final a consort diagram that shows the numbers, flows of the patient. And I want that you take a look, we have a spotlight on the experimental arm. We have 251 patients, and we find at the completion of treatment 243 patients. That is to say, the patient gave straightly to the end of completion of treatment like a train, with only a few discontinuation due to withdrawal of concert or some adverse event, but the patients are still on the progression-free survival curve. We have I can treat 231 over 246 patients as complete responders, and less PR and progression of disease than the comparator arm, where we have a more trouble path with the intensification phase. Let's move on. And so this is the progression-free survival of the comparisons. And I want to stress the progression-free survival rates of the experimental arm. At 3 years, 0.87 versus 0.73, and so the target endpoint of a delta percentage of 10% in progression-free survival was met. I want also highlight this 92% of progression-free survival at 1 year, because today many trial shows at 1 year impressive progression-free survival while the enrollment is still ongoing. These are major results with a 30-month follow-up analysis. The hazard ratio was 0.45, and the events were in the experimental arm were half of the events that we observed in the other arm, in the comparator. And this is event-free survival. And we keep the difference. As I told you, we had also considered discontinuation for any reason, so these events burdened a little the survival curve that kept anyway their significance. The complete response rate at the end of treatment was significantly higher in the experimental arm, and the complete remission was kept was maintaining through the follow-up years, and as you can see, we have more than 90% of disease-free survival. Partial responses and primary refractoriness were significantly different in favor of ABVD dose-dense, dose-intense, and this percentage, 4%, is the same that we observed in the escalated BCOP program as it is been presented in the HD 18 trial. It seems that early intensification can enucleate, can sort out a fraction of primary refractory patients. The overall survival is high. Obviously, we had a low number of that. 7 were due to lymphoma, and infection affected 1 patient per arm. This is really interesting. As you can see, the difference was kept immutate or even became wider for stage 4 between the 2 arms. And I want to highlight the results of the interim PET. As you can see, the PET-positive patients treated with the experimental arm achieved a 72% progression-free survival. That is the same progression-free survival rate that was achieved by the PET adaptation strategies overall.
1 minute.
Low fraction of discontinuation for adverse event, a small numbers of delayed treatment, so those intensities of the drugs was kept. This is toxicity. It is a higher toxicity, mainly hematological, in the PET-adapted ABVD. There is a misunderstanding about that, because we can think that the PET adaptation strategy keeps the same toxicity profile as a standard ABVD. We have 20% of patients that undergo an enhancement of treatment through salvage treatment and autologous stem cell transplantation or escalated BCOP, so we have an additional toxicity in the PET-adapted strategy as compared with the normal, traditional ABVD strategy. It would be more correct to describe the treatment toxicity in terms of PET, more than in terms of arms of treatment. This is the toxicity profile, mainly hematological and gastrointestinal, of patients presented by patients that underwent the 4 courses of ABVD due to PET negativity in the PET-adapted arm. And this is the ABVD patients treated only for 2 cycles and then intensified. So we have a grade 1 toxicity and we have a more hematological toxicity. And this is the toxicity of ABVD-DDI, and with very low events of cardiac and pulmonary toxicity. And this is the final, this is the conclusion. So we can say that ABVD-DDI outperformed the PET-adapted program, and the primary endpoint was met. Obviously, we need to have more data on long-term toxicity to refine the trade-off between risk and benefits of ABVD dose-dense, dose-intense. Anyway, one can say that by itself, the ABVD combination, the old ABVD combination, retains in itself the potential to achieve a CR rate greater than 90% and to realize progression-free survival rates approaching 90%. These are things that previously one can imagine only for the escalated BCOP program. So we believe that this is a major advancement for a chemo-only treatment. And more data will be available to better understand the meaning of these results and probably to have a spotlight on the refractory patients to such intensified treatment with the ongoing Fil-Rouge bio trial with regards to ctDNA genotyping. And this is all for this first presentation. And I don't know if I go to the next.